Morning from Miami Beach is Dr. John Bennett broadcasting for Neurosurgical TV. Today we have Yuha's China Neurosurgery Grand Rounds with a special guest, Vinko Dolenk. Before I turn it over to Yuha, let me thank the translators and introduce them. Hello, Ben. How you doing?
Yeah, thank you, John.
Yeah, thank you, Ben. Thank you very much. And Takashi?
Hi, good evening. I'm Dr. Kon from Tokyo, Japan. Translating Japanese.
Japanese, that's great. Okay, great. Okay, Yuha, thank you very much, and it's all yours.
Okay, hello everybody. Hello, good friends. After Christmas break, we are here again. So with Vinko Dolenk, with one of the most famous neurosurgeons in the world. Like I always say, there are very few people who would change the world, but Vinko Dolenk is one of them. And he made the route to Cavernous Sinus, and coming from an extremely small country, Slovenia, he could manage even behind the iron cart, he could manage. So Slovenia is an extremely small country, even smaller than Finland, where I'm coming from. So between 1 and 2 million people became independent, 91. Ljubljana, I've been visiting. It was a very nice visit in Ljubljana. Everyone in Slovenia knew Vinko's name. So you have just to ask, where is Vinko? And then they will show you. So this is Vinko Dolenk, one of the most famous neurosurgeons in the world, coming from a small country, made a breakthrough all around the world and has been operating around the world. He was also in Helsinki many years, operating on, doing beautiful scalp-based surgery. And this is Vinko Dolenk. So let's give him a speech. He will speak about Cavernous Sinus tumors now, with the experience of more than 3,000 cases. This is an experience no one else in the world can repeat that. Okay, Vinko, go ahead.
Okay.
Perfect.
Thank you very much, Juha, and the other members of the team. You are helping that this can happen. This is my privilege and honor to be invited to your grand rounds. Today, I would like to share with you my lifetime experience in cavernous sinus tumors treatment. So the title is Central Skull Base Tumors, actually the cavernous sinus tumors. But first of all, I have to mention that the cavernous sinus is in the central skull base and has its connections, free connections to the other compartments. And so the tumors can enter into the cavernous sinus by direct spreading from sella then along the cranial nerves 3, 5, and 6, but also by direct invasion of the cavernous sinus through the walls from the bones at the skull base. There, if you talk about the entrances, then we have to talk also about the exits. Of course, this is two-way roads to the orbit, to the sella, to the posterior fossa. The cavernous sinus is named as a suite in the hotel. So it signifies, this is the title, the name of two rooms connected. And from the cavernous sinus, the tumor can pass to the orbit through the superior orbital fissure. It can pass also to the sella, and it can go into the bony sinuses and even extradurally by direct extension. Today, I would like to talk about the benign tumors of the central skull base. It is clear that any malignant tumor from the vicinity, from other compartments can come in, but I would like to focus on benign, so-called benign tumors. And these are pituitary tumors, large and giant, which are spreading beyond the sella. Then trigeminal Neurosurgery, Chordomas, chondrosarcomas, and chondromas, Meningiomas, Cavernomas, cholecystoma, and even thrombosis of the cavernous sinus can be listed. And then the most important group are meningiomas at the skull base in the cavernous sinus. Large and pituitary adenomas beyond the sella, you see they count up to 24%. And there is a tricky spread of the tumor from the sella into the cavernous sinus, where they can pass freely to the cavernous sinus, and then they can spread along the CN3 intradurally, causing the splashing of the third nerve over the surface of the tumor, and the tumor is pinching the nerve against the sharp edge of the dura. How it looks like, this is sella, and where the dural ring and the proximal ring are coming together, they are forming the lateral membrane of the cellar compartment. But there are some windows where the tumor can freely go out into the cavernous sinus. Here is the artery, and then it goes along the artery and along the third nerve posteriorly. And it can come, and it does come many times into the intradural space behind the posterior clinoid process. Now, the question is how to get the tumor from sella out from transphenodal space. It's clear and easy. How to get it from the cavernous sinus? It is also possible, but it is difficult to get the tumor out by transphenodal approach when it is behind the posterior clinoid process, because it comes along the third nerve through the oculomotor trigone, and then it comes into the posterior fossa, bulging here and pushing the third nerve upwards against the sharp edge of the dura. So the question is, what surgical approach? I do not like to discuss with endoscopic specialist about the surgery in the sella and even in the cavernous sinus when the tumor is soft. But I think that when the tumor is in the posterior fossa, behind the posterior clavernous process, it is better to use the transcavernous extra and intradural approach. Then, this is the approach, just a diagram. We open the lateral wall of the cavernous sinus. We visualize the third, the fourth nerve, and V1 and V2. And then we can enter the cavernous sinus on the lateral side of the third nerve and medially to the fourth nerve. We remove the tumor as much as we can. In the next step, we push the fourth nerve medially, and then we come to the carotid artery. We can mobilize the medial loop of the carotid. We can clean the tumor on the medial aspect of it. Then we go over the medial loop of the carotid, and we come toward the sixth nerve and the deep parts of the cavernous sinus, and we can remove it completely. And we can remove also by this approach the tumor which is in the sella and in the cavernous sinus, as you can see here. Or another case, before and after, here. And another one like this, here is empty again, and then we can, no, it doesn't work now.
Še enkrat, boš klik, dvakrat klik,
Kje je to?
nazaj,
Ja,
nazaj.
ja. No.
Klikaj dvakrat,
Ja.
z miškom. Si veš, ne?
Okay, this is how we approach. We are on the right side, and the inner layer of the lateral wall of the cavernous sinus is still in place, covering the nerves. This is V2 or V1. V1 is this, V2 is this. The dura was peeled off from the lateral wall. I am cutting now the inner membrane of the lateral wall between the V1 and the fourth nerve in so-called Parkinson's triangle. And now I will come to the tumor. These tumors are usually soft and with small pressure against the nerves, you can enter the Parkinson's triangle. You see the fourth nerve here, and this is V1. We go a little bit further. Now we are removing the tumor from the cavernous sinus. There are some adhesions which can be cut. You just have to know where you are. This is V1. This is the fourth nerve. And the third nerve is hidden here. And underneath is the carotid artery. We are working now on the lateral side of the horizontal carotid in the cavernous sinus. The carotid will be this way and then goes this way. The tumor is soft, as I said, and easily reachable and extirpated. There is nothing underneath there. There is empty space. There is the whole of the cavernous sinus. This is the carotid already. Now I'm going to the, you see the carotid here? The carotid, which is coming from lateral loop upward to the medial loop. Some strength, some adhesions. You have to cut this. And in this direction will be the sixth nerve coming from the posterior fossa through Dorello's canal or Dorello's space, as we call it. This is the carotid. Now, the carotid is free. This is the horizontal portion, and this is the medial loop, fixed here with the adhesion. We cut this, and then we have a free entrance between the carotid nerve and the fourth and the third nerve into the sella. We can go both ways, from the lateral side and from the medial side. I prefer to use here a little bit larger instruments in order not to damage the carotid. Now we are going toward the pituitary gland. Then we open the dura, and we can press the diaphragm cell and push the tumor outward. And we can push it from intradural to extradural, and we can remove the tumor from extradural side, from the cavernous sinus and from the sellar compartment. In this way, we preserve the diaphragm cell. And we work exclusively from the cavernous sinus and sellar compartment. My assistant is helping me and is pushing the diaphragm cell down, and I can clean in the cavernous sinus and in the sellar. So when the tumor is coming also more posteriorly and into the posterior fossa, pushing the diaphragm cell and spreading behind the posterior canal process, I can remove it from there. When we visualize the pituitary stalk, as you see here, this is the optic nerve, pituitary stalk, carotid is there, and the cavernous sinus is free, and also the sella is free. Then we put the fibrin glue into the cavernous sinus, and we put the sutures on the dura. Then we come to the trigeminal neuronomas. They are exclusively extracavernous, and they account up to 5%. We operated mostly virgin cases, 94%, and recurrent or rest tumors in 6%. When the tumor is originating from the V1 or V2, then it will spread anteriorly. And due to the long-standing compression, it destroyed the bone. And this tumor was found on a regular check in the school when they tested pupils for the vision. And he was not aware of the tumor. Later on, he was operated, of course, and the tumor removed completely. When the tumor is located a little bit more posteriorly at the gasserion ganglion, then it can spread anteriorly and posteriorly. Anteriorly and also posteriorly. When it is originating from below the root of the fifth nerve, it will spread exclusively into the posterior fossa. This is the case, and this, or such a case, removed completely from the retrosigmoid approach. For this one, we don't need to go subtemporal. But when the tumor is larger and is also in the middle fossa and posterior fossa, we can remove it by subtemporal approach. We go through the apex of the pyramid, and this is the situation after removal of tumor, complete removal. So sometimes we have a situation that the patient experiences sudden attack of pain in the distribution of the fifth nerve. What does it mean? It means a major bleeding into the tumor, like this. Usually, if the patient is not operated, this bleeding will subside in 2 to 3 months. And I have some patients, they were not able to get operated, and they are without pain after 3 months until the next bleeding may occur. The trigeminal neuronoma might be very close to the bony sinuses at the bottom. They can destroy the bone and also the membrane, and they can cause CSF leak. Then we have a sympathetic fiber tracts, schwannomas. They are exclusively intracavernous. They are very few, and they are completely different at surgery in comparison with trigeminal neuronoma, which are usually soft, sometimes cystic, and easily to be removed. While these tumors are very hard. And here is such a case. I operated once in Helsinki. Juha provided this patient, and huge tumor on the left side. You see the carotid is pushed downward. One would think that this is very difficult to operate. No, it is not so difficult, because the tumor, which is exclusively intracavernous, does push carotid on one side, usually downward, and the nerves upward. So the nerves are on the surface of the tumor. We can go a little bit faster. So we remove the sphenoid wing here, the then anterior clinoid process, and then we remove the wall over the orbit. Here, this is the temporal lobe. Only a small portion of the temporal lobe over the tumor. We go down to the lateral wall. So far, nothing difficult. The difficulties start later on when we try to remove the tumor. We can easily peel off the dura from the lateral wall. Now we are approaching the second division of the fifth nerve, and we are exploring the tumor. This is the tumor. We are just peeling off the dura away from the lateral wall. To protect the brain, we put a stitch, and then we pull up the dura, and we can visualize the whole mass of the tumor, which is huge. Then we start reducing the tumor because we know where we enter the cavernous sinus space, and we know that there is only tumor below the nerves and above the artery. This tumor was extremely hard. You have provided a special instrument to cut it off, but also this one was not very helpful. The third nerve here over the tumor, and V1 here. Look, this is V1, V2, and underneath is the sixth nerve. Now we remove a larger piece of the tumor away from the carotid, which will be seen now in a moment. Look, this is carotid now down there. So these are the nerves and the carotid, and that's it. Now we come to chordomas, chondrosarcomas, and chondromas. They are also quite sizable group, 4% of all tumors at the skull base. And we were operating on 70% virgin cases and 30% of recurrent tumors. Chordomas, chondrosarcomas, and chondromas, they cannot be completely resected. None of them. Why? Because they originate from the joints between the bones at the skull base. And it was also found that the gamma knife was not effective on these tumors. So we found, together with some people from Boston, that the proton beam radiotherapy is very efficient. And I remember the first case I operated in Zurich together with Professor Yashargil, whom he operated before and could not get into the cavernous sinus. So he sent the patient back home. This was a young Italian patient, very charming boy, singer. And when I came to Zurich, he invited him to come back. We operated on him and then removed the tumor. We were very, very happy. Professor Yashagil was satisfied, and so was I and the patient. But 1 year later, the tumor came back. So, what to do? We reoperate. And then again, the tumor came back. So we finally realized we had no. So we were then combined the surgical treatment with proton beam. And the politic is that that we remove the tumor which is bulging into the brain, and we leave the skull base, which can be treated then later on with the proton beam, like here. Here. And another case after surgery here. In some cases, we find these tumors incidentally. People are sent to imaging for trauma or whatever, and they find the tumors which the patient were not aware of. And some patients could not accept surgery. And we were following them, and nothing happened for some years. So not every tumor needs to be operated. This is such a case. And again, partial removal, and then the base is heated by the proton beam. And again, the space is created by a resection of the tumor in front of the brain stem, and later on, the skull base is treated by proton beam. Here we have a very interesting case, a young girl who had the squint at 3 years of age. And then there was successful physiotherapy for 2 years. And then the squint disappeared. Second time, the squint appeared in 16 years when the girl was teenage and worsening despite so-called physiotherapy. Father, mother, and the patient, daughter, teenage, came to me, and they were fighting in front of me. Father wanted the girl to be operated. Mother and daughter, they said, no, we will continue with physiotherapy. It came to my mind that I had a slide where I found an aneurysm on the carotid artery in the cavernous sinus, and then over this aneurysm was the sixth nerve fixed with sympathetic nerves, sympathetic cords. So I was reasoning that the sixth nerve, which was this distended over this bulging could glide on one or the other side while the lesion was extending when the sympathetic nerves were torn. And so happened with this girl. So we convinced her to operate. This is before operation, this is after operation. And the same case before and after. And again, the same case before and after. Later on, she had a proton beam, and now she is living happy life. Rare benign lesions in the cavernous sinus, hemangioma, cavernoma, polycertoma, and even thrombosis. For hemangioma, I just would like to mention that they are exclusively in the cavernous sinus. They don't go beyond. And what is important, they cannot be removed with piecemeal technique because with each bite, you cause new hemorrhage and you may exsanguinate the patient. So it's better to coagulate the hemangioma and dissect it from the nerves and then remove it as a whole when it shrinks. We had only one case of thrombosis of the cavernous sinus. The patient came to us with a huge mass in the cavernous sinus, and in few weeks, the thrombosis was somehow resolved, and surgery was not necessary. Now we come to meningiomas. They, at the central skull base, they amount to the 47% of all tumors. There are many publications about the meningiomas, but we were not able to publish because we had the impression that each kind of meningioma at different central skull base locations are different. So we have 12 different locations. Sphenoid wing, anterior clinoid, middle fossa, intracavernous, intracavernous plus other compartments and so on. Sphenoid wing, the tumor cause hyperossification of the lateral wall of the orbit and can be easily removed, and compression against the orbit also removed. And if there is involvement also of the lateral wall of the cavernous sinus, it can be also removed, and this is a rather simple operation. Anterior clinoid process meningiomas, they are a little bit more delicate because you have to be aware of aerization of the anterior clinoids. And as we promoted so much extirpation of the anterior clinoid, in these cases, we don't suggest it. We suggest to remove only the outer layer of the anterior clinoid, not entering the air cells, because if you do this, you will have a CSF leak, and this is a serious complication. And here, then the tumor can be removed. Another, this is a type, Al-Mefti was discussing about these meningiomas, and his publications are very useful because he divided these meningiomas into those, they enter the artery wall, the ICA, and those they do not enter. So you have to be always careful about this possibility. Otherwise, you can remove the tumor pretty well. The situation here, and after surgery, And here is a peritumoral edema because of CSF arresting, compressing also the arteries, and this is the after resection. It is not necessary in nowadays to remove the tumor completely from the cavernous sinus when you have the impression that the tumor is too sticky, is too much adherent to the structures. It's better to stop, not to damage the nerves or the artery, because you have another possibility to treat these lesions, and that is gamma knife. Another case, before and after. Another one, practically complete removal. Another anterior clinoid. You see, the part of the tumor in the cavernous sinus is remaining. And this one we start treating with additional treatment with gamma knife whenever it starts growing. Similar case, a young engineer, the tumor was removed. He did not have a cranial nerve deficits, and the tumor is somehow excised completely. Now, middle cranial fossa meningiomas. These meningiomas are sometimes from some people sold as cavernous sinus meningiomas, but they are not cavernous sinus meningiomas. They are meningiomas originating from the lateral wall of the cavernous sinus. As you can nicely see here, carotid is pushed a little bit medially and displaced in comparison with the other side, normal. But the tumor is only in the lateral wall. So you can easily remove it and preserve all the structures. You don't even touch the V2, V1, and fourth and third cranial nerves, and you can remove the tumor completely. Similar case, after removal, similar case, again, you see only a small asymmetry in the carotid arteries. The same case, and after surgery. Paracellar space intracavernous sinus meningiomas. These are meningiomas, they are only in the cavernous sinus, not spreading into the orbit or sella or posterior fossa. It's a pretty large group, but again, you have to go ahead to remove the tumor, to resect the tumor until you are safe, and of course the patient. This is such a case, removal, and you see the anterior clinoid is missing after surgery and the tumor is removed. Or on the other side, another case, the tumor, which is spreading along the tentorial edge, was resected. The very last portion was left and followed. But here, the situation is clear. The same case, and after surgery, the same case, and after surgery. Now we come to the most numerous, the largest group of the paracellar space and adjacent regions, almost 400 cases among the whole group. The tumor is in the middle fossa, posterior fossa, and in the cavernous sinus. You remove it so far as you feel safe. Don't go too far, because we have a gamma knife. Gamma knife cannot be provided for such a big lesion, but can be provided for smaller lesion around the artery whenever it is necessary. So the big mass is removed. The small rest can be treated later on with gamma knife. The similar tumor, posterior fossa, middle fossa, cavernous sinus, and for this tumor, you can say it is soft, highly vascularized, and suckable. Why? Because the diameter of the ICA here, where the tumor is almost the same as on the contralateral healthy side. This is the same case. You see the diameter of the carotid, which is pushed downward and medially, is actually the same as on the healthy side. You see the diaphragm, the lateral wall of the cavernous sinus. This is intracavernous. This is in the middle fossa. And this is after surgery. This is one of the very important case. You have to think twice before you operate and before you decide for how far you will go. You see the lateral wall of the cavernous sinus. The tumor is in the middle fossa. It's in the cavernous sinus. But the carotid artery is very narrow. What does it mean? Is this infiltrated by the tumor, or is it just stenosis due to the compression? It is both. Severely stenotic intracavernous ICA, meningioma invasion through the adventitia of the artery wall, critically devascularized artery wall by too aggressive surgery may rupture after surgery. I had 3 ruptures after surgery. And this is not a pleasant situation to solve. So it is better to stop with resection and to leave a small coat over the carotid, not to injure, to create injury of the carotid wall, and then the artery will even expand. But if the tumor starts growing again, then you come with gamma knife. And this is the same case. You see, if you damage the carotid in the cavernous sinus, and this carotid has no anterior cerebral artery from this side, because both ACA2 are originating from the left ACA1. So if something happened to this carotid, then the patient will have stroke. Another case sent to us from another country when we operated, and we had a rupture of the carotid during surgery. So we were able to put the anastomosis, to make anastomosis from the proximal and distal stump, and then to reinforce the suture line with cuff clips. This is another projection, the same patient after the tumor resection, and this is the cuff clip, and vascular tree is established. This is a very important. People are talking about calcifications in the tumor. It might be, but this is not calcification. These are ossified inclusions And if you see such a tumor, be aware that this surgery will be extremely difficult because the tumor is fibrous, extremely fibrous, almost no vascularization, hard and difficult to remove. So you can remove only the extra cavernous and along the tentorial edge, but don't exaggerate in the cavernous sinus. Superior orbital fissure, meningiomas. The meningiomas are spreading into the orbit, and this is also another difficult situation. Then Dorello's canal, or we call it space, is very rare. We had only 5 cases. And I'm asking you, is this a canal for the sixth nerve, or is this a space in front of the Petroclival ligament and behind the bone of the skull base? The nerve is coming in front of the Petroclival ligament and then climbing up over the carotid. And when the tumor is located here, it is quite difficult to be safely removed. And it may happen that you find a nerve, a tiny nerve, and you may mix the sympathetic nerves with fasciculi of the sixth nerve. And that is very important to be aware of the anatomy and of the possibility that the sixth nerve may be composed of several fasciculi of the sixth nerve. This is an interesting case. This lady was a nurse working on a department of diabetes for many, many years. And she had some troubles with the vision. She was complaining for double vision, and they told her that she has a diabetic retinopathy, neuropathy. But it became worse and worse, and finally I was able to convince people to perform MR, and we found this tumor which was compressing the nerve at the Dorello's canal. This is the tumor, this is after surgery, and this is the tumor. You see where the nerve is passing, and this is after surgery. The lady recovered, but not completely. Petroclival meningiomas, the tumor which grows from the apex of the pyramid and is bulging medially into the brainstem. This is before surgery, this is after surgery. These tumors can be also removed practically completely and without difficulty. You just have to know the approach. And this is the same patient before and after. You see the pons regained the shape after surgery. And this is the approach. We are on the lateral side. We expose V3, Gasserion ganglion, V2, V1, and then also the root of the fifth nerve. We remove the tumor from the posterior side. We visualize the carotid posterior loop and remove the tumor completely. But the job is not done yet. The tumor is also below and anteriorly to the root of the fifth nerve. So when we removed additionally the bone downward, we came in front of the root of the fifth nerve. We were able to transpose the the root of the fifth nerve posteriorly, visualize very nicely Gasserian ganglion, V3, V2, V1, and then we could remove the rest of the tumor bulging into the posterior fossa, down to the sixth nerve, brainstem. And we were following the sixth nerve, how it comes through the Dorello's space or canal, whatever you like, into the cavernous sinus. And the tumor is completely removed. Tuberculum cell meningiomas. These are quite a number, and then they can be easily removed by lateral approach, like this, complete removal. The same complete removal. And this is the intraoperative. We are coming from the left side. We visualize the V2, foramen rotundum, the lateral wall of the cavernous sinus, optic strut, optic nerve extradurally, when the nerve was exposed in the optic canal, the walls were removed. So it looks like intradurally, the nerve is pushed laterally on one side, on the other side. And this is the tumor here. And finally, we were able to remove the tumor completely and liberate the chiasm and both optic nerves. Similar here, but this is another more difficult case. We are approaching it from the right side. The orbit is here, optic canal, optic strut, lateral wall of the cavernous sinus, and anterior clinoid process. We open the dura along the Sylvian fissure, and we expose the nerve in the optic canal. And we realized that the ligamentum falciforme, the dural part, is compressing the optic nerve. But not only this nerve is suffering also posteriorly when the ACA1 is stretching as a wire over the optic nerve. The tumor is pushing from below and upward, and then compressing the nerve against the falciform ligament, against the ACA1. You see the optic nerve is very hemorrhagic, but is still functioning. After removal of the tumor and liberating the optic nerve, visualizing the pituitary stalk, basilar artery, the tumor was completely removed, and both ICA are free, optic nerve, right and left are free, chiasm is free, and this is the so-called wound of the optic nerve on the right side. This is a huge tumor at the tuberculum cell. They were operating on this patient almost the whole day. They exsanguinated her, but they did not remove the tumor. This is before our operation, this is after our operation. What they did, they were coming prefrontally and, sorry. I hear you. Huh? Let's see. Sorry.
It's okay.
Okay, okay. Yeah. Yeah, yeah. Well, my God, what I did now.
Can you open the PowerPoint?
Yeah.
Yeah,
Dit is
Okay, now open the screen share. It says share screen at the
yes,
bottom.
yes,
Yeah, share screen.
sure.
Yeah, share screen. You gotta use that. Oh, that's okay. There's no hurry. We'll get it.
Fatiga partida.
Hmm?
Fatiga partida. Fatiga na mão.
You got it.
Yeah.
There you go.
Okay.
There you go. There you go.
Okay. What's
Okay, that's okay. You're getting there. Try it again. That's okay.
Okay. So,
Vou escolher nesta slide.
yeah. Why a minute? I don't know why he doesn't hold it.
Screen.
Should be here, yeah. Hold on.
Deixa eu ver. Screen partida.
Huh?
Também
Screen
não.
one. Sorry.
It's okay. There you go. There you go.
Yeah, now I would like to go a bit. Yeah. Okay, here we are.
Peraí.
Here we are. This is this case. They were working a lot. They were destroyed the frontal lobes, but they left the tumor in. So finally the patient came to us and we removed the tumor completely. Now we come to the diaphragm cell and optic canals meningiomas. These tumors are very, very tricky. They are small. They are not big tumors, but they grow into the optic canal. So not a big mass, but endangering the optic canal, the optic nerve in the canal. And this is what is, sorry. In these cases, in those nerves, in those tumors, neurosurgeons should be honest to himself and to the patient, to the point that it hurts. These are the words of Drake, and I completely agree. Because here you cannot be heroic. You have to be only very, very careful. And before you drill the bone of the optic canal, it is better if you try to train yourself. Don't drill perpendicularly. You have just to brush the shell of the egg, not to go through the inner membrane, because the inner membrane is in reality the optic nerve. And for that reason, it is extremely important not to damage the nerve, not to jump into the nerve and to destroy it or damage it structurally, and not to damage it with the heat. You just do some revolutions of the diamond drill up and down, up and down, up and down, like with the rubber. And then you will come to the inner membrane. And so you will come into the optic nerve in the optic canal. So you should avoid the structural and heat damage of the nerve. And this is the situation in the operation. And further on, when we remove the tumor from the optic canal, we see that the surface of the optic nerve is rough, is not shining, while in the orbit it is shining. In the intradural part, it's also shining. So only this is diseased. And we were able to preserve the function, or better say, we were not damaging the persistent nerve fibers of the optic nerve, and the patient has the vision as she had before surgery. Then I said, but madam, we have to operate you on the other side too. She could not accept. She said, I see on my right eye completely normally. So I said, okay, but it may happen that I will be somewhere around the globe and I will not be here. Like I cannot operate you when it will start deteriorating. And it actually happened. Some months later, she started deteriorating on the right side. She became blind on the right side, and now she is living on this safe 20% of the vision on the left side. I have another case, similar. Lost the vision on the right side and started losing the vision on the left side. And we were able to remove the tumor and to visualize the nerve which was damaged in the optic canal. Later on, the patient was insisting to try to see what is on the right side. We opened the right side and we found the yellowish optic nerve degenerated. We were able to decompress and dissect the tumor away, but of course the vision did not improve. And now we come to the very interesting case. A beautiful lady of 34 years of age, blind on her right eye from when she was 17 years. They said to her, oh, we don't see nothing, we cannot help, you have another eye. Now she is losing the eye, the vision on her only eye, and is coming down to 20. What to do? Gamma knife, cyber knife, nothing, cytostatic, what? We have to enter and we have to remove the tumor. No. We are on the left side. The dura is heavily impregnated by the tumor. We are looking for the optic nerve. We are resecting the tumor with the impregnated dura, drilling of the bone, which is also hypertrophic. We are on the medial side of the optic canal now. This is the optic nerve here. We are on the medial side. We have to open the optic canal. And then when it is open, we have to resect the dura, which is also impregnated with the tumor in the optic canal. But keep in mind, we are working on the only 20% of vision this patient has. She is the mother, has children, and is middle-aged. So she does not like to lose the vision also on this side. According to the orientation of the vessels along the optic nerve, we were armed by some knowledge from the peripheral nerves, which I did years ago, and in the carpal tunnel syndrome, when you see the zigzag vessels, then you know there is a terrible stenosis, and then the release is not so effective. And so when we saw here the longitudinal orientation of the vessels, we were somehow relieved. We removed all the tumor from the lateral side. Now we are going more laterally, and now we will also see the third nerve. We are following the third nerve. So as radical as possible. But the tumor is also underneath on the dorsum cellae. So we go from the medial side of the optic nerve, and we remove also the tumor underneath. Toward the pituitary stalk. Now the optic nerves are free, diaphragm, the chiasm is free, the pituitary stalk is there, and that is what we could do. The vision is preserved. So it is different when you are dealing with the tumor. Sorry. Which is big, which is away from the vital structures. Now we are operating the same lady on the right side, where she is blind. She has been blind for 17 years. Why we are operating her on the right side also? To remove the tumor and to prevent that this tumor will spread to the left side. Extremely adherent tumor invading the dura. So we resected everything, impregnated. We had some bleeding from the sella. We put some fibrin glue. Then we removed the hyperossified bone. See, this is the tumor over the nerve. We are almost in the bony sinuses. The thick dura. So this is, in a way, a prevention of spreading of the tumor from the right to the left side, where is the only functioning eye now in the lower capacity. The right and the left optic nerve and resecting everything. The surgery doesn't look nice. It's an ugly surgery, but useful. The optic nerve chiasm, the nerve on the left side and nerve on the right side, which has been under compression of the meningioma, spreading along the nerve into the optic canal and destroying it. And you will see here now what is rare situation to be seen, that the tumor invaded also the nerve. You will see here now. You see, the tumor is in the nerve. The tumor is in the nerve. Look. So these are very special tumors at the diaphragm cell and at the optic canals. This is the lady. Oculomotor function were preserved. She's blind on the right side, has some vision on the left side. And she is living with this now. Now we have another cluster of meningiomas located at the posterior clinoid process, dorsum cellae and upper clival region. And this is rather easy to be removed. You just have to approach laterally and below the brain. This case and complete removal. Another case. The tumor is at the dorsum sella, also at the diaphragm sella and insella, and reaches also the tuberculum sella. Then we have a clival meningiomas. There are not so many clival meningiomas as people claim, because people claim Petroclival meningiomas, clival meningiomas. They claim dorsal posterior clinary process meningiomas, dorsum sella meningiomas spreading to the clivus. They named them clival meningiomas. No, this is not correct. What counts is the origin from where the tumor starts. And this is a clival meningioma. Really very much compressing the brainstem, extending along the whole clivus. One may think that this is very difficult to remove. It might be, but this particular case was not difficult. Why? Because you can see the cleavage line between the tumor and the brainstem. And you can see after removal of the tumor also some reshaping of the pons. And then we come to the more difficult cases. These are giant central skull-based meningiomas involving over the midline to the other side. What to do with these cases? Not to attack them from the healthier side, attack them where the carotid is more compressed, because it is very probable that the meningioma started from here, where the carotid is more affected. It's not so difficult to remove this part of the tumor, but it's more difficult to remove the inner part of the tumor. Such tumors, I prefer to operate in 2 sessions, to remove first from the right side as much as I can, and then come from the left side. Recurrent or arrest meningiomas. The question is to operate or not to operate. I think, as I mentioned already before, the neurosurgeon should be honest to himself what he or she can do and what he or she cannot do, and what is possible. Because if you have such a tumor, this patient was operated by a well-known neurosurgeon and was told that the whole tumor was removed and that she does not need any imaging before 1 year. When she came back in 1 year with this image, she was told, yo, but your tumor is growing like a mushroom. No, it was not correct. This tumor was not removed. This is not the recurrent tumor. This is a rest tumor. So we have to be honest to ourselves. Are we able or are we not able? And we have to tell to the patient the truth. I cannot do it. Please try with this and that institution and ask other people. We were able to remove most of this tumor, but this is the rest, which has to be hit with a gamma knife. The same patient, other projection, and the same patient, other projection. So we were able to remove quite a big amount of tumor, but not complete. And we have to tell this to the patient. Not completely, the tumor was not completely removed. You will need gamma knife. You have to follow this situation with imaging in regular times, intervals. Or another case, also operated twice and the tumor was still there. Is it only breast or also recurrent tumor? I cannot say, but we were not able to remove it completely. And that's a sad story, actually. And the most difficult case, which I was faced with, was this. Operated in 2 other institutions, and all the cranial nerves were damaged, but the tumor was still compressing the brainstem. So we removed this part of the tumor, but the cranial nerves did not recover. But do not forget, when you operate as the second surgeon or the third, you are responsible for all the deficits from the first and the second surgery. So you have to think twice before you accept such a case and promise to the patient amelioration. And this is I think, the most difficult task for everyone to judge before. And that's it, what I had to say. Thank you very much.
Okay, I'll get you up the screen share there.
Okay.
Okay, Warlicks and Juha, do you want to lead the discussion?
Okay.
Thank you very much, Vinko. It was wonderful lecture. So huge experience.
Thank you.
One can repeat that anymore in the world. So thank you for sharing your experience. It was really wonderful. And
thank you. I don't like
something
to be,
very, very important.
I don't like to be discouraging, but I just ask for a serious approach before surgery, and not each tumor is of the same size is the same difficulty for surgery, and we have to be aware of this. And nowadays it is better. It is easier because we have some people around the world who have more experience, and we have some institutions. They collected more larger volume of such cases, and we always have time to consult them and to be more clear to the patients what is possible and what is not.
I'm not aware of that kind of institutions, so you have the largest experience. Vinko, you have the largest experience in the world, so it was wonderful lecture. Thank you very much.
Thank you. Thank you. It was my privilege.
Okay, Vinko, we have a comment from a Mongolian neurosurgeon that says today his team operated on a clivus chordoma surgery by a transoral approach. It was the first time he did that case in Mongolia. So
Moldova.
Yeah, Mongolia. Yeah, I've never met someone from Mongolia. Wow. Okay, I think we had another.
Was it successful?
Was it? Yeah, let me ask him. Was it successful? He apparently does not have audio, so he can text me back. I think, Harshad, did you have a question you wanted to ask? Are you there, Harshad? I think you had one before.
Hi,
Go ahead, Harshad.
thank you, Professor. Excellent lecture. Wonderful to listen to you. Excellent lecture. I would like to ask you one question. If the tumor, which is at skull base, which is like meningioma and plaque, involving the cavernous sinus, and also extending to superior orbital fissure, what do you suggest? What will be your approach, sir?
What? I didn't catch the question.
Meningioma, like an plaque,
Yes, yes.
involving the cavernous sinus and going towards the superior orbital fissure also. How do we remove this?
Yeah. You have to dissect the nerves. Actually, you have to be first very careful about the crossing of the fourth nerve over the third nerve. This is because in the intracranially, the fourth nerve is on the lateral side of the third nerve. And then close to the superior orbital fissure, it goes over the third nerve and comes to the medial side. So you have to be, first, you have to be aware of this. Then you cut medially to both of these, to the fourth and the third nerve, you cut the annulus zin, and then you can enter the orbit. Now it's the question of luck. How soft or how hard is this tumor? Unfortunately, there are more hard tumors, more fibrous tumor than easy to remove or to suck. So this dissection is very, very demanding when the tumor is fibrous running into the orbit. You can remove the tumor from the orbit also, but this passage from the cavernous sinus through the superior orbital fissure into the orbit is the most difficult segment and most dangerous segment, I would say. So, but you achieve a lot. Look, you achieve a lot when you follow the third and the fourth nerve and V1 to the to anterior side, and you somehow liberate them. You open the closed annulus, and then the tumor can, the nerve can function better.
Okay, I believe Atul Goel has a question. Go ahead, Atul.
Okay, John, thank you. So, Vinko, it was a fantastic lecture on cavernous sinus surgery, tumor surgery. And there is no question that this lecture on cavernous sinus was from the emperor of cavernous sinus, from the king of cavernous sinus, without any doubt. And those who are, the young people in the audience who are listening to this emperor, you must know that this emperor belongs to a very small, tiny little town of Europe. And from there, he learned, he did dissection after dissection, dissection after dissection, and wrote some tremendous manuscripts, tremendous books on the subject of cavernous sinus, from where the cavernous sinus surgery was actually born. So what you have heard is from hard work and extensive experience over several years and a very honest presentation. And I have a feeling that We all have to learn from this great giant of cavernous sinus surgery. Cavernous sinus surgery is still absolutely relevant, absolutely important. There are so many benign tumors which involve the cavernous sinus. Apart from meningiomas, you have to know about hemangiomas, you have to know about trigeminal neuromas, you have to know about chordomas, you have to know how to transgress cavernous sinus, go into the clivus, you have to know about how to, break into the corridors of cavernous sinus, which our great Professor Vinko Dolenz has taught us and to the whole world. There is no question that to achieve such an experience and such a mastery of cavernous sinus, it will require a generation of neurosurgery and a huge experience to reach this level of mastery. So I've heard you, Vinko, for several occasions in my lifetime, and it is always a pleasure and delight to hear your fantastic comments and fantastic and honest presentation. Thank you, Vinko.
Thank you, Artur. I appreciate this very much from you, especially because I know you spend more time in the operating theater than outside. And you are also carrying the problems from the OR when you go out. And that's why I think you will agree with me that this kind of work is not a job. It is a kind of living. But if I go a little bit to your command, how I feel now after so many years of working in the cavernous sinus, my fear is growing. I'm even more afraid now as I was when I was more ignorant, At that time, I said, oh, do this, do that. But then I realized, even with the simple anterior clinoid process, you may have a big problems when the air cells are coming from the splanchnocridium, and you are not able to remove it. You have to remove just an outer shell of the anterior clinoid process. So each step is becoming more and more difficult because it is more knowledgeable. You know more, you fear more. It is not that you are going to the panic, no, but it requires more preparation, more training, and more safety, So we have to, as Drake said, we have to be honest to ourselves first and then to the patient. Because if I'm not able to do something, it does not mean that nobody can do. I have to send the patient to somebody else or some other institution. They may have a different experience and so on. So we have to be honest to share the knowledge and to share our capacities. Personal capacities are very important. Thank you so much. Thank you so much.
Thank you.
Okay, I believe we have a question from Dr. Kabulo, a neurosurgeon from the Congo. Dr. Kabulo, are you there?
Congo.
Yes.
Yes. Thank you so much, Professor Dolenz, for this wonderful presentation. I'm Kabulo, neurosurgeon in Lubumbashi, Democratic Republic of Congo. I personally met Professor Dolenz in Amman, Jordan 3 years ago. We did the cadaveric dissection. So it's again a pleasure to meet the king of cavernous sinus today. Prof, I have a question. You mentioned, I don't know if I got you well, that when the artery is stenosed and you decompress the tumor, you got 3 ruptures of that artery. I don't know if I got you well. Now, my question was, in case the tumor was invading the wall of the artery. How do you repair now after the rupture? Because I assume the artery is now friable after invading the wall. How do you repair it?
That's very important question. And first, before I answer the question, I have to congratulate you. You were very much somehow involved with the preparation for your marriage when we met in Amman. Did you marry later on?
Of course, yes, Prof. Thank you so much.
Congratulations. But you were also very attentive to our dissections and so on. So
thank you, Prof.
According to your question, you have to be prepared for such occasion, and that's why you have to dissect the anterior loop of the carotid around the anterior clinoid process. This is distal, and then proximal in the posterior loop in the petrous bone. So you have to have these 2 points. If something happens while you are preparating in the cavernous sinus, and if the artery is the tumor is glued to the artery and may rupture, then you just put the temporary clips, and that's it. And then you can repair the carotid. But of course, you have to have the cross circulation imaging before any intracavernous surgery to know if the cross circulation will be sufficient for the time you will use for the reconstruction of the intracavernous carotid, either direct or stump to stump, or even putting the short high flow graft. So if you have if you prepare the posterior loop and anterior loop free where you can put the clip, you are safe.
Okay, Ahmed.
Thank you so much, Prof.
Oh, go ahead. Go ahead. Was someone speaking?
No, I was saying thank you for the answer. Thank you, Prof.
Thank you.
Okay, very good. Ahmed Asar asked, what is the best approach for clival meningiomas and tricks during dissection besides the basilar artery?
What is the best approach to the clival?
Clival meningiomas.
Yeah. You have to open the clivus. And the clivus, you have to open the cavernous sinus first, anteriorly and then posteriorly. Anteriorly, it means that you remove the anterior clinoid process, you remove the posterior clinoid process, and then you go down the clivus, down the posterior clinoid to the clivus. From the other side, from the posterior, you go through the apex of the pyramid, you resect the apex of the pyramid, you transpose the fifth nerve posteriorly, and then you you drill off the rest of the apex of the pyramid down to the posterior clinoid ligament. And then you're on the clivus. You just divert, you just retract a bit the whole cavernous sinus laterally, and then you are aligned to the base of the clivus. So you come from front, you come from side, from the through to the apex of the pyramid, and then you have you visualize practically the whole length of the basilar artery. from the joining point of both vertebrals and the dividing point of both posterior cerebral arteries.
Okay, I don't know. I don't think this was asked before, but what do you do if you inadvertently injure the ICA during cavernous sinus tumor surgery?
You have to repair it. First of all, according to the quality of the tumor, you have to decide to how aggressive you can be. Namely, we studied this when I was in UVA in the United States, in Charlottesville. We resected some completely invaded carotid in the cavernous sinus. We resected it, and then the pathologists, they investigated. They prepared this in so-called Jombini solution, and the whole circles of the carotid was studied. And what they found, that the tumor interrupt, destroy the adventition, and then it grows into the muscularis of the wall of the carotid artery. And if you proceed, if you coagulate the vasa vasorum of the wall of the carotid artery, you create dead areas in the wall, and this can rupture. It's fine if it ruptures during surgery, then you can fix it. But if it does not rupture during surgery, it ruptures later on, then the patient will die. I had 3 ruptures after surgery. One on the 7th day, one on the 10 days. 2 patients died. The 3rd one I was able to save while I was in the hospital. But otherwise, this is a rupture after surgery is a very difficult complication. So it's better in such cases when the tumor is hard and glued to the artery, just leave a sleeve of the tumor around the artery and just coagulate the tumor. Don't remove the last piece from the artery.
Okay, I believe Benedicto, do you have a comment you would like to make?
Yes, thank you very much, Dr. John. I would like to thank Professor Dolenk for the excellent lecture. I was in the first group of Brazilian neurosurgeons that went to Ljubljana in 1987 to see Professor Dolenk do cavernous sinus surgery. At that time, cavernous surgery or cavernous sinus was considered a no-man land. Since then, I have operated several patients with cavernous sinus tumors, not like Professor Dolenk, but I could do something for my patients, and I believe that many Brazilian neurosurgeons can do this now. But till now, I am learning a lot with your lectures. Thank you very much, Professor Dolenk.
Thank you very much. Thank you. Regards to Brazil.
Thank
Okay.
you.
Obrigada. Okay, more comments or questions from the panelists? Now's your chance. Oh, Guy, hello. How you doing in Jordan?
Hi, Dr. John. I'm fine, thank you. Hello, everybody. It's an honor for me always to present these great, actually, lectures. And Professor Dolenz, this is me, Rida, from Jordan. I'm a young specialist in neurosurgery, and I'm really honored to have to share your surgical expertise, which is extraordinary and really fantastic. I hope you all do safe and well among this COVID. I don't want to waste your time. I just want to go straight back to my question, which is actually for you, Professor Dollens. During your approach to the cavernous sinus, would you first remove the mid-orbital band before removing the medial wall of the sphenoid, just before you reach the dura, or it's not an obligatory step to do? I hope my question was clear.
You know, it's we always come to this question how to approach. Number one is to remove enough bone of the squamma of the temporal bone. When you come far laterally, then you can proceed down the bone, and then you peel off the dura from the lateral wall. And when you come anteriorly to the area where was the anterior clanoid process, and when you come posteriorly, when there is foramen spinosum and middle meningeal artery, you just peel off. Be aware of the greater petrosal nerve, not to damage it. And then you peel off and you visualize the V3, V2, V1. Now, this is actually only the entrance into the cavernous sinus. This is the first step. But then the second step is what you need. If the tumor is in the cavernous sinus, you will need to visualize, to dissect the carotid in the petrous bone, as it is described in my literature, and behind the anterior clanoid process to get access to the carotid. If something happens when you are working in the cavernous sinus. If the problem is not in the cavernous sinus itself, but is outside of the cavernous sinus and only partially in the cavernous sinus, then you open only anteriorly when the process, the tumor is around the anterior clanoid process, the diaphragm, sella, and posterior clanoid process, you open just there. But you have to have, for the security, explored posterior loop of the carotid. If something happens, most of the time it doesn't happen, but thank God. It's like if you go out and you have no umbrella, it will rain. If you have umbrella, it will not rain, you know. But it's better to have an umbrella, you know. But when you are working posteriorly, is another second part of the approach. You go posteriorly to the trigeminal nerve, to the root of the posterior, and you get into the apex of the pyramid, and you drill from the below and upward. So you have to go underneath the fifth nerve and not to damage or not to open the inner auditory canal, because there you can damage the 7th and 8th nerve. But you have to practice this in the lab, you know. So, in general, remove as much as possible of squamma. Come to the bottom, to the lateral wall of the cavernous sinus. Visualize it from the area of the anterior clanoid process back to the petrous bone. And then, if you need the second step to enter the dura, to enter the cavernous sinus anteriorly and intradurally around both clanoids, you go only anteriorly. You don't need to go posteriorly. Or the same if you go in petroclival regions, you need more posteriorly, not anteriorly. So it's you have formalized this in your brain. You have to put yourself on the lateral wall of the cavernous sinus, and then you look north. There is anterior and posterior canal process. You have to look south. There is petrous bone. You have to look east and west. But you have to put your homunculus into the cavernous sinus, not to observe the cavernous sinus from very far. No, you have to go in. But go in the lab.
Yes, definitely. Thank you so much. Thank you so much, Professor Dollins. That was so great explanation. I do appreciate that. Thank you.
Okay, welcome, Madame.
Thank you.
Danu,
Thank
you
you.
look like you have a question. Danu Rolian, neurosurgeon from Indonesia.
Oh,
Good evening, Professor. It was a divine, godlike lecture tonight. I have never felt like overwhelmed with the lecture. I might have missed some of your explanations about the optic nerve sheath meningioma. It was very small, yet very morbid to the optic nerve. My question would be, how do you take care or take care of the ophthalmic artery during this section of the optic nerve? Do you retract it, or do you please, Professor,
that's
enlighten?
very, very, very important question. First of all, train yourself not to drill, just start drilling and then keep drilling. No, you have to talk with yourself. Oh, me. You talk, one of you talk to other you. Please make only a few revolutions with the diamond drill. 2, 3 revolutions, then stop. Stop. Irrigate. You will not jump in and you will not create too much heat because you can damage the optic nerve also with the heat, Not keep drilling. Few revolutions, stop, irrigate, revise. This is number 1. And then brushing the wall of the optic nerve. So when you come almost through, then you can even break this tiny shell, You never go into the nerve. The question about the ophthalmic artery is a very difficult, and I'm not sure I can answer the whole spectrum of it, because the vascularization of the optic nerve is very tricky. Sometimes it goes only from the ophthalmic artery peripherally. Sometimes it goes also backward. Sometimes you have a vascularization of the optic nerve from other sources. So the ophthalmic artery has to be preserved. And you can preserve the ophthalmic artery this way that you cut the dural ring. You cut the dura and you go laterally to the optic nerve and then just proceed. Small step by another small step, and you will find the ophthalmic artery. The distance between the dura and the origin of the ophthalmic artery is about 0.1 to 2 millimeters away from the dura. You see? Sometimes the ophthalmic artery is extradurally. Then you have to be even more careful, and try to open the optic canal, and then you will have a help because you will cut the dura and then you lift the dura and falciform ligament, and then you will see where the ophthalmic artery is going in. Usually it is inferior lateral to the optic nerve, but it might not be, you know, that's, but it is important. In many cases, I heard from many people, they said, oh, it's not so important if you damage the ophthalmic artery. Yes. In some cases, there is nothing will happen if the vascularization comes from the other origins. But if it is dependent on the ophthalmic artery, the patient will be blind. So this is a must to preserve the ophthalmic artery.
Okay, very good.
Thank you. Thank you, Professor Doling.
Okay.
Thank you, Dr. John. And
sure, anytime. We welcome your questions. Okay, I think we have time for one more question. I want to keep Dr. Dolenz too long, Dolenz and Juha. Anybody have any
Professor
questions or comments?
Dolenz? Yeah.
Go ahead.
I have the last question. Yeah. You mentioned sometimes you have to left some tumor piece on the ICA wall to protect the ICA. So at this time, at this kind of condition, you couldn't see the ICA wall very clearly. So how thick you would determine by what kind of technique, like ultrasound or other technique? So you made the decision.
You can
how
use,
thick? Yeah.
Yeah, you can use ultrasound, but this I did in the States. I did not at home because I didn't have it, this tool. But if you leave about 2 millimeters of the tissue over the wall, you know. So, but I avoid this problem by the way of dissecting the ICA in the healthy side where there was no tumor.
Okay.
Then I came to the tumor from proximal and from the distal side. And then you see where the tumor is becoming hard, glued to the artery wall. Then you say, oh, it's better to leave a sleeve over and around. And it works. It works.
Yeah. That's very smart. Yeah.
Yeah.
So congratulations. Tonight there's, I think, around 3,000 audience in Chinese WeChat channel.
Thank you.
Excellent, excellent. Venko, did you ever see the day you'd be lecturing to Chinese, Japanese, and English audience all at the same time?
Never, never.
That's right, from the comfort of your home.
I had to travel to Sao Paulo. I had to travel to Santiago de Chile. I had to Mexico City, to Seattle, US, to Kyoto, Japan.
Yeah, it's another way to travel.
I have to thank you.
Yeah, thank you, Takashi. Thanks, you, Ben, and thanks for bringing Venko, Juha.
Giancarlo. Thank you, everybody. Thank you, everybody.
Any plans, Juha, for next week?
Yeah, we will let you know.
Okay.
Tomorrow.
Okay. Very good.
Tomorrow.
Okay.
So we will
thank you very much.
Good lectures.
Thank
you.
It's difficult to make better lectures than Vinko made today. His lifetime experience, so it is so huge experience. So we have to thank Vinko very much, and we are grateful.
Thank you.
Okay, very good. Just hang around. We'll end broadcasting. Thank you, everybody.
Thank you.
Thank you. See you.
Thank you.
Bye.
Thank you. Bye.